Are you curious about Gestalt language processing? You are not alone. Join me, Corinne Smoose, and speech therapy PD for our podcast, The Gestalt Get Together. Our episodes try to balance the enthusiasm and excitement about GLP and its associated intervention ideas, as well as a healthy dose of skepticism about how to understand and integrate this paradigm shift into your career and the field at large. We hope that you can get together with us to learn more about Gestalts.
Welcome to SLP Learning Series, a podcast series presented by SpeechTherapyPD.com. The SLP Learning Series explores various topics of speech-language pathology. Each season dives deeper into a topic with a different host and guests who are leaders in the field. Some topics include stuttering, AAC, sports concussion, teletherapy, ethics, and more. Each episode has an accompanying audio course on SpeechTherapyPD.com and is available for 0.1 ASHA CEUs. Now, come along with us as we look closer into the many topics of speech-language pathology.
Welcome to the first episode of the SpeechTherapyPD.com mini-series, Making Sense of Selective Eating. My name is Maddie Metcalf, and I'm a speech-language pathologist with an interest and passion for pediatric feeding disorders. I'll be your host for this podcast, Making Sense of Selective Eating. This evening, we will have Stephanie Cohen joining us for our first guest. Today's course is 1 hour and will be offered for 0.1 ASHA CEUs. If you're part of the ASHA registry and want your CEUs reported, you must have your ASHA number and address in your SpeechTherapyPD.com profile. Please allow 1 to 2 months from the completion date for your CEU to be reflected on your ASHA transcript. Now, without further delay, I'd love to welcome Stephanie Cohen, MA CCC-SLP CLC. Stephanie is a speech-language pathologist and a certified lactation counselor in private practice who has worked with children with complex medical needs and their families for more than 20 years. Stephanie has advanced training in pediatric feeding and specializes in working with the birth to 3 population. She is passionate about helping families of children with feeding challenges find ways to make mealtimes more successful and enjoyable. Stephanie has a Bachelor of Arts and Master of Science degree from Northwestern University. She maintains a private practice in Illinois and is a credentialed evaluator and provider in the Illinois Earlier Intervention Program. Stephanie regularly presents on a variety of topics, including typical and atypical feeding development, responsive feeding, and trauma-informed feeding assessment and treatment. Her work can be found through the Get Permission Institute, Chicago Feeding Group, Talk Tools, and the American Speech Language Hearing Association. Stephanie enjoys mentoring and has been invited lecturer at Northwestern University. Stephanie is the author of my first Learn to Talk board book series. Most importantly, Stephanie is a mom of 3 who lives in Illinois with her family. My financial disclosures are that I receive an honorarium for hosting this podcast. And Stephanie's are that she maintains a private practice and is a co-founder of the Get Permission Institute. She receives an honorarium for participating in this podcast. Stephanie maintains a social media account on Instagram, YouTube, and TikTok. It's at Learn to Talk with Me. I'll post it in the chat, where she occasionally receives compensation from feeding supply companies when sharing products she recommends related to pediatric feeding. Stephanie receives royalties from her board book series, My First Learn to Talk books. My non-financial disclosures are that I'm a volunteer for Feeding Matters, a member of ASHA and ARCSHA, and a member of SIG-13. And Stephanie's is that she's the co-founder and co-director of the Chicago Feeding Group, a 501 organization. Welcome, Stephanie. Welcome to Making Sense of Selective Eating.
Thanks, Maddie. I'm so glad to be here. Thanks for that wonderful introduction. I just want to say, I think that the lineup and learning experience that you have put together is really incredible. So I'm just really excited to watch it unfold.
Oh my gosh, thank you so much for saying that. I'm really excited. I definitely kind of crafted this series to be what I needed when I was starting out with pediatric feeding, because it's such a complex area and I had no idea what I was getting into when I said, I want to work with feeding disorders. So super excited. Well, shall we go ahead and jump right on into the good stuff?
Yeah, you know what, Maddie, can I ask a question before we do that?
Sure.
One of the things that I always love, because I always feel like these virtual platforms are a little impersonal, I would just love to see if the attendees would mind throwing in the chat where they're from and what their discipline is. I just like to know who I'm talking to.
Oh, I love that idea.
Yay.
Yeah.
So if you all don't mind, that'd be great. Okay, sorry.
And I'll go and start off. I am a speech therapist in Arkansas. We have somebody from New Jersey. Hi, Erica.
Yay.
Texas, Olympia, Washington, San Diego, California, SLP in Southern California, New York, North Dakota. So happy. There's so many people here from all over.
Yay. Thanks for coming, everyone.
Yes, thank you so much. Currently in the sniff setting, maybe you'll learn some good stuff also because I don't know, I think there's room for carryover.
Hey, Liz, I'm glad you're here to learn. This is incredible. I'm so happy.
Um,
We need more good feeding therapists, Maddie. This is like a much needed workshop.
Absolutely.
That's
So
great.
excited. There's so many from all over. What's everybody's experience with pediatric feeding? Just also out of curiosity.
Oh, good
You
question.
want to throw that in the chat? Are you just getting started? You've been doing it for a while, here to freshen up?
I see Liz is brand new to feeding, which I saw just a moment ago. So that's great.
No experience. Miriam, hopefully you'll learn a lot.
Oh,
No
this is
experience
so
in this area yet? Okay,
you all, this
this,
is like the best area of practice. I know I'm biased.
yes.
Nothing brings me more joy after 23 years than sitting at a table with a family and just like getting to know them and helping
Mhm.
to make things easier. So you're in the right place.
Awesome. Well, it makes me happy that we have some new people. Hopefully this will be a good roadmap for you as you navigate this, working with some new clients. And hello to the one that's been doing it for a while, but looking to learn more. We love a good lifelong learner.
Yes.
Okay, so Stephanie, can you define the terms selective or picky or selective eating for us?
So I can try. Maddie, one of the things you and I talked about at length when we were just getting to know each other and thinking about what we were going to talk about today is that, historically in our field and in other fields that also help support kids with feeding challenges and their families, there have been lots of different terms that have been used over the years. And selective eating is one of them. I think of picky eating, extreme picky eating, sensitive eaters. There's so many different ones. And so when I think about what a selective eater is, I guess my first question when I hear that term is I ask the person using it, well, what does that mean to you? I think that a lot of these terms, a lot of these names that we sort of have for kids and their feeding patterns, language is powerful. They sort of communicate maybe a sense of like something being wrong, right? Pathologizing an eating pattern. And while we know that lots of the kids and families that make it to us are in fact really struggling in lots of ways, I am not sure that these terms really give us any meaningful information besides they are coming to us for help because they feel that things are challenging for them.
Mhm.
I think selective eating is just sort of one of the possible terms that we might hear when a family comes to us to ask for help with meal times.
How important do you think it is that we use a uniform word for this among like disciplines and other professionals?
That's such a good question.
I know we didn't touch on that one. I just thought of it.
Yeah, but I think a lot about it, and I think it's really important. And so I, of course, was really glad to see the pediatric feeding disorder diagnosis introduced and adopted
Yes.
by lots of practitioners. The thing I really love about having that as a unifying diagnostic term is it prompts us to think of all of the ways that feeding challenges can impact a child's life and functioning, right? We know like medical, psychosocial, skill, and nutritional status
Mhm.
is, all those domains can be impacted. So I think it's really valuable to use a common term or a diagnostic term that prompts us to think holistically and from lots of different perspectives. I do struggle, I have to say, I struggle because I think that as we grow as a field and as we listen to folks who have had their own journeys around eating in lots of different ways and learning about food, I have been approaching my work a bit differently and starting to kind of avoid labels just in my everyday practice because I feel like it sometimes narrows my focus and sends me down a path where I may be looking for certain things or pathologizing a certain pattern. So I think it's really important for lots of practical reasons like insurance and medical documentation and collaboration on a multidisciplinary team, because if I do an evaluation and you get a report from me and it says pediatric feeding disorder on it, you have an idea of, some of the questions you're going to ask, right? And what you're going to be curious about. But I think that as a field, we all are still learning what terminology is the most supportive to kids and families.
I and just for so everybody knows why I chose the name Making Sense of Selective Eating for this podcast. So I used to just call it picky eating. And after reading some really great books, I'm not sure if it was Sherry Fraker or Marsha Duncline, but one of them said, I don't like the term picky because they're being selective because they are choosing foods for a specific reason to them. So they are selecting their food. They're not just being stubborn and picky because they are temperamental. They're communicating something to us. They are selecting that for a reason. And while selective eating is part of a bigger picture of pediatric feeding disorder, most of the time I get a kiddo with a PFD on my caseload, PFD short for pediatric feeding disorder, because selective eating is the primary symptom that kind of gets picked up on by doctors, or the parents are like, I can't get them to eat anything besides one brand of chicken nuggets. And so that is where the name of that podcast came from.
I love it. And I will tell you, I was talking to Marsha Duncline yesterday about this conversation tonight, and it was her because one of the things that I always hear her voice in my head, throughout my whole life, because she's incredible and I've learned so much from her. But specific to this topic, I hear her saying, exactly what you just said. This child is selecting what is working for them in this moment, and they may be selecting it because they can't breathe when they drink from that bottle versus this bottle, or because, they're allergic to something and it's not working for their body. So I think you picked the right term. And I think that as a field, it's our job to remind ourselves that selective just means they're choosing. It doesn't mean bad or good or, limited in some way. So
such an important thing to remember.
Yeah.
Can you explain a little bit about the difference between typical and atypical selective eating?
That's another good question.
I know, hit you with the real big doozies tonight, Stephanie.
Well, you know what? I actually love that we're having this conversation at the sort of start of this series, because when I meet a family, I do a lot of listening at first. And my job is to get to know the caregivers and get to know the child and really get to know them as a dyad or as a family unit. And one of the things I think a lot about is, why is this caregiver worried? Why is this child worried? And so I think that, yes, we have our specific diagnostic criteria if we're looking at something like a pediatric feeding disorder diagnosis. But if we're thinking about selective eating, I think it is hard to make a specific and definite differentiation between typical and atypical selective eating, just because it means different things to so many people. However, what I will say is, if a family is coming to us and they feel stress about their child's experiences at mealtimes and their family's experiences at mealtimes, it obviously warrants our attention and our support. So I guess maybe the way to think about it is, there are probably lots of selective eaters walking around, and maybe the ones that make it to us are the ones for whom the challenges rise to the level that this family says, something's not right, we need help.
I love the emphasis that you put on parental stress and feelings towards that, because I know in my practice, the way that the parent feels about the mealtime, the way they approach that mealtime can have such a big impact on the child as well.
Yes.
Can you talk a little bit about why it's so important? Just dive into that a little bit more about why it's so important to approach eating through that family focused lens.
Oh, absolutely. This is one of those things I could talk about for many hours. So, as you know from your learning, and as those of you who are here and who are listening on demand can find out and dive into, there is so much research on the lived experience of caregivers when they are raising a child who is struggling around mealtimes for some reason. And we have learned so much about what increased stress and worry, the impact that that has on caregiver feeding practices. So, I am a responsive feeding practitioner. I prioritize relationship and believe that you cannot separate feeding development from the context of a relationship, because children and adults learn in that context together, and their interactions are bidirectional, right? And everything that happens at a mealtime impacts the response of the other participant. So we really are working with, as I said, a dyad or a family, and not just a child who we're trying to get to eat, so to speak. There were quotes for those of you who are listening on the podcast. My hands were in quotes because I know that and believe and share that it's not our job to get kids to eat. It's our job to help children feel safe and feel trust within their mealtime relationships, so that they are able to eat, so that they feel ready for learning. So probably the most important piece of that is helping parents understand their children, because I think a lot of times parents who make it to us, they're pretty worried and pretty frustrated, and they have tried everything that they can think of to help their child to eat. And we know from the research that when feeding challenges are present, there is decreased enjoyment at mealtimes, there's increased conflict in relationships, families feel isolated, families feel confused and overwhelmed, and there's a lot of strain in a lot of different areas. So we really need to think about a child in the context of their family and their environment and their community, so that we can make sure we're thinking about all of the different variables that impact their feeding development and their experiences every single day.
I love that. My practice changed when I first started off. I was like, okay, I'm a therapist. I'm going to take them back. I'm going to work my magic. We're going to look at this carrot 5 times. We're going to have a great session.
Me too.
And like my session focused on getting the kid to eat. And when we learn and we know better, we do better. And
Yes.
so whenever I started shifting my practice to focusing more on that like relationship based, understanding the child, understanding the parents, and not just looking at the child as my patient, but the family as a whole as my patient, that was whenever I saw such a shift in my practice. And I started making like actual progress that we all felt good about it.
I love that. My favorite part of what we do is when, and hopefully we get to this point, is when you get to a point where a parent says, "Oh my gosh, things feel so much better at the mealtime." And
Mhm.
we are so lucky as clinicians to have so many researchers that are looking into these lived experiences. I think of, Dr. Britt Pados and Dr. Meg Simeone at Harvard, and so many others, Maureen Black and Frances Abood, Leanne Birch, so many people. I'm happy to provide a list of references that, I have learned from. And so when we think about our work, integrating the knowledge we have from all of these different papers and studies that have been done, we really can understand just how pervasive the impact is on family members when a child is struggling, when they're worried.
Yeah. We had somebody ask a question. They
Oh,
said, I once worked with a young boy who could eat past feeling full. So the one-on-one aide had to portion his meals every day. I was told his brain didn't tell him he was full. He was on the heavy side to be only second grade. Would that be considered an eating disorder? If so, what is the official name?
so there is a diagnosis, a syndrome called Prader-Willi syndrome, and part of that condition is a lack of sensation of satiety. And so those kids receive very specific types of treatment. That would be something that we would refer to a medical provider and collaborate. So that's one possibility. There are other things that might cause a child to, well, I guess the question is, how do we know that that child has
Mhm.
eaten enough? Because if we think about the goal of supporting kids to be able to eat, we're not really thinking about it in terms of what's their body size. We're thinking about that child as, is this a child who is learning to be able to tune into their internal sensations and eat when they're hungry, eat the foods that their body is telling them that it needs, and then sense when their body says, I've had enough fuel for this mealtime. So I think that's a complicated question in the absence of that specific diagnosis that we know that that's a significant part of it. Otherwise, I think we might ask ourselves, how do we know that he was eating past the point of satiety? You know, how do we know he wasn't hungry? I mean, there are some kids who just have a bigger appetite, who grow in larger bodies. And so I think that those are some of the questions that I would ask.
Yeah. I had my kind of went same train of thought. I was like, is there a Prader-Willi? What else is going on? The other thing I want to touch on is that they use the term eating disorder. So there is a difference between eating disorder and feeding disorder. So eating disorder is going to fall under that like psychological domain, be treated by like mental health providers, whereas like pediatric feeding disorder falls under ours. The one little kind of like overlapping area would be avoidant restrictive food intake disorder, which is ARFID. But there's lots of really interesting research coming out on that right now. Feeding Matters has a consensus group going on to figure out like what that overlap looks like. So that's something to just be mindful of as you're thinking about like eating and feeding disorders and all that good stuff.
Yeah, they're doing some great work. They had I really enjoyed their workshop in this year's conference.
Yes, it was very interesting. And I felt just a lot more clear on what ARFID was. Okay, so since that one, I feel like that little case study that we did kind of led us in nicely, and then just now talking a little bit about Feeding Matters.
Yeah.
So can you start off by explaining, since we do have some people that are new to feeding that are on, can you kind of explain what the 4 domains of PFD is?
Yeah, I know that some of us are live and some of us are listening on demand, but one of my favorite resources to better understand this is the Family Guide from Feeding Matters. And so I encourage all of you SLPs to take a look at that, because it really breaks it down in such an easily understood way. So there's the medical domain, and that just prompts us to think about all of the different, parts of our functioning that support our ability to eat, and all of the different things that could potentially go wrong, or be happening in a child's body that could interfere with their ability to eat and enjoy eating and feel comfortable. I think Feeding Matters has a list of over 300 different diagnoses that could potentially be associated with pediatric feeding disorder. So that medical domain is a big one, and things that fall under the medical domain are things like, aspiration. Malnutrition is under the nutritional domain, but that certainly can be connected with some of the diagnoses that a child might have. I think about the kids that make their way to us with cardiac conditions, or who are premature and have a diagnosis of bronchopulmonary dysplasia or chronic lung disease. There are so many different underlying medical conditions that impact a child's learning experiences around eating and their body's ability to eat safely. So when we think about the medical domain, we're really thinking about who are those medical specialists on the team that can help us answer some of those questions and collaborate with us as the speech language pathologists as we're supporting, what we see at mealtimes and helping to keep that child safe. The nutrition domain is just what it sounds. So a child with pediatric feeding disorder certainly could have, issues because they're not consuming adequate calories to support their growth and weight gain. They could have deficiencies in different nutrients and micronutrients. So I feel in almost every case need to be collaborating with our registered dietitian colleagues who can really help us understand this specific child's body and their needs, and help us to understand and really actually help parents to better understand what it is that their child needs. So that's the nutrition domain. And really, you can probably already begin to see how much we all overlap. The feeding skill domain is very much where we sit as speech language pathologists and our OT colleagues as well. And that's, exactly what it sounds like. How is a child chewing? How are they self-feeding? How are they swallowing? Sensory processing and sensory functioning falls into that domain as well. So those are the things that impact whether a child is able to manage certain foods or manage a specific flow rate from a bottle, or, do well with breastfeeding or chest feeding. So those are the things that we probably focus on the most in our discipline. But, psychosocial, the fourth domain, I think is also what we need to be thinking a lot about as we collaborate with our mental health colleagues, being pretty careful to stay within our scope of practice. The psychosocial domain, it's somewhat, there are some different parts to it. So when I think about the psychosocial domain, I think about what's the emotional impact? What's the psychosocial impact of having a child who struggles to eat? And we think about the impact on the parent, or the caregiver, on the child, and then on that relationship. We do also know that there are certain psychological conditions that can impact mealtime learning and the feeding relationship to the extent that that could be the primary driving factor in, causing a child to have feeding challenges, or, having, a situation in which that child is continuing to have feeding difficulties. So there are lots of different pieces to that psychosocial domain. And it's really, really important for us to understand as speech language pathologists when the appropriate time is to make a referral to a mental health practitioner. And, in a lot of ways, I work primarily within the early intervention program here in Illinois, and we're lucky enough that mental health practitioners are part of the early intervention programs. I do a lot of advocacy and education and just outreach around helping the administrators and sort of the gatekeepers, like the service coordinators, understand why it may be important to bring up mental health support from the beginning and really destigmatize it for families as they're coming into the system and starting to understand all of the different ways that we're going to be thinking about the challenges that they're bringing to us. So I hope that helps clarify a little bit, but definitely check out that family guide. I know we're all professionals, but the family guide is great. I think it gives us the language to be able to communicate everything that I just talked about to families in family-friendly language, and Feeding Matters has just created like such a wonderful resource. And obviously there's also lots of resources geared geared primarily towards professionals as well.
And so for anybody that's on the live, I did attach the links to the article that was written by Dr. Godet and a really awesome team in 2019 that gave us our consensus definition for PFD, which led to us getting the ICD-10 codes for the pediatric feeding disorder. And then I also attached a link for the family guide, and then like a what is PFD with like the 4 domains, where it's a really nice little graphic where it has like an orange circle in the middle that says pediatric feeding disorder, and then 4 little bubbles on the outside showing medical, nutrition, feeding skill, and psychosocial. Had another really great question that I'll ask really quick. So when do you use R1311 for the dysphagia oral phase code versus like R63.31 or R63.32, which is the chronic PFD or the acute PFD codes? And if you have any tips on how to distinguish between the two.
Yes, for sure. So ASHA has a really nice article page in their practice management portal, if you're a member of ASHA, talking about ICD-10 coding and how to figure out which one is appropriate to use. I have been using the pediatric feeding disorder code. And the one thing that we didn't mention, Maddie, is that there's a distinguishment between acute and chronic. So there's 2 different codes. And so I would recommend taking a look at Feeding Matters information about coding and the information on the ASHA practice portal when you're looking to make decisions about which one to use.
And so now that we've covered the 4 domains of PFD, can you kind of talk about how the 4 domains can impact selective eating and how like that might show up among the 4?
Yes. Okay. So, as you might imagine, lots of the things that I talked about as I was going through the different domains can impact a child's functioning, right? A child's ability to eat when the opportunity is offered, sense hunger, tune into their internal sensations, and then eat enough for their body to feel satisfied at a given opportunity, right? And so, if we think about the medical domain where, a child may have been premature and has a diagnosis of chronic lung disease and has difficulty as a result coordinating their sucking and swallowing and breathing, that may lead to that child being very selective about what works for them during a mealtime experience. It may not work for them to take a volume of formula or human milk at a mealtime. And as they transition, I think that when we're thinking about those younger kids, like young infants, I'm not sure if selective eating is really the term that I would use, but I think that with kids who have these types of medical challenges, things that happen to them, or even just maybe not a diagnosis, but negative experiences around eating that starts that young, sometimes it leads to challenges when they transition to solid foods. And I think that stage where kids are learning to manage solid foods starting in the second half of the first year of life and onward, that I think is when we start to think about some of these terms like selective eating or picky eating, because we have this perception that a child should be trying lots of foods and eating a variety, right? And when a child, for whatever reason, has difficulty with a specific situation, opportunity, food, consistency, they then will select what works for them. So in that way, any number of medical diagnoses that impact digestion, that impact cardiac function, that impact breathing, that impact sensory functioning, that impact muscle control, right? All of those things for each individual have the potential to lead to positive or negative experiences with specific foods or eating experiences, right? And so as a child learns from those opportunities and figures out what helps them to feel safe and what causes them to feel unsafe, they're going to start to select the things that work for them. So I think that's probably the best way to conceptualize it. And, as we think about the intersection between the medical domain and the psychosocial domain and the skill domain, I think a lot about then how the impact of whatever the original sort of thing was, the first thing, the first experience, the first disruption in learning around meal times and bonding and attachment and strengthening of that relationship and establishing trust, right? That child's ability to trust their own body, to trust food, to trust the people who are feeding them or the people who are offering them the opportunity to eat. I think it gets very, very layered. So it could change day to day, and I think it often does, what the driving factor is in a child's selectivity. But, as we think about how many meal times families have over the course of a day and a week and a month and years, all of that learning is so powerful, and it just can lead to very, very specific preferences that children have in order to feel safe. So I that was sort of a big answer and not as specific, but I sort of think it's a broad question that doesn't just have one answer. I think any of the things that we might see in any of the four domains can impact a child's selectivity over time based on what's working for them in a given moment.
Yeah. And what I really liked about your answer is that you just really touched on, it's not just the medical domain exists on its own in isolation and the feeding skill exists on its own in isolation. It's all so interconnected and intertwined, and it really takes an interdisciplinary approach to effectively treat a PFD.
Yeah.
And so I think that yours just really touched on that. Another thing that I thought was really interesting is how you talked about how there can be so much variability in meal to meal, day to day, and what our kids are eating. And it made me think of a course I went to at ASHA last year by Kelsey Thompson. She presented on dynamic systems theory. And it was basically just saying there's so many, I think there's 6 or 7 different variables that can go into changing how we are developing a new skill. And that can significantly impact feeding. But that just gave me a really good lens to look at through my patients, because I'd have patients that came in and we would have an amazing session, and then the next day they'd come in and it'd be like, wow, this is a train wreck. We didn't get a whole lot done. But there's just so much variation in where that child is, where they're coming from, what their sensory experience has been like that day, and all that stuff. And then going back to whatever lived experiences that they've had that could have been triggered or something before they got to you in that moment.
You're so right, Maddie. And you, as I was listening to you, I started to think about something else that we haven't really talked about yet, but I think is an important part of the answer to the question that you asked and what we're talking about now. And that is what a child shows us on a given day, what they actually do. And, I think sometimes when we think about words or labels like selective eating or picky eating or problem eating, we might think about it, or some folks might think about it as something a child does, right, as behavior. And as a responsive feeding practitioner, I'm always thinking about a child's actions as communication. So the problem is not that the child is refusing, quote unquote, my finger quotes are up again. The problem is not a child refusing to take a bite or refusing to eat a quantity or refusing to, my fingers are up, they're going crazy. But when a child shows us, no, this is not working for me right now, it is communication. And oftentimes, at least with the kids that I see, the little babies and toddlers, and even those school age kids and maybe even older, they don't often have the words to understand their experience. All they know is, I don't feel safe. This isn't working for me right now. And so one of the reasons I love thinking about the different domains and the intersection and the layers with relationship is that our job is not to do the thing to get the child to do the thing, right? It's not our job to get kids to eat. And I think the first person I heard put it this way is Jenny McLaughlin, who I'm so excited that you're having in one of the episodes. And so I always think about her words, and you'll hear lots of folks saying this right now, including Marcia Duncline. But it's our job to help a child feel safe and comfortable and ready for learning when it's right for them. And so I don't even remember where we started with this question, but the thing you said that made me think about this is, yes, the variability, that's what it was. Our job is to say, who is this child, or wonder, who is this child in front of me right now today? And who is this parent in front of me right now today? What kind of day are they having? What kind of week have they had? What other stressors are going on in their life, right? Has there been a death in the family, job loss? Has there been travel? Has there been another type of stressor, financial instability? So many things that impact a family's life and functioning. And so our job is really to look beyond that surface of the actions of the child and maybe the caregiver, and just be curious and be sort of a person who helps families feel like, we are there for them as a strong relationship and a support to help them to maybe find a little bit of stability in whatever's going on in their life. So our job is, we have to think about a lot of different pieces when we're working with families.
I love once again that you hit on that family piece and talking about being that source of stability for them, because I've definitely found sometimes with my feeding kiddos, a lot of times I have to play the quarterback, and I have a kiddo on my caseload that had cystic fibrosis, and her mom told me the other day, she said, Maddie, we were talking with her CF team, and me and mom, after working with her for a little bit and not having a lot of progress, it's I really think we should refer to GI. Our volume is so low. And the team was that's just a typical thing with kids that have CF. It's fine. You don't need to go to GI. But mom was everything that you've said in my gut is telling me that we should go through, and I already have the appointment.
Yeah.
And she went, and we started on a appetite stimulant, and we got reflux medicines because the endoscopy found that we had chronic inflammation in her esophagus. And so it sent us down this little path where we made a lot of good progress. And I, playing that hat and kind of stepping into those other domains to make that referral and have those hard conversations with mom, you know, it felt a little bit at times when I was maybe stepping a little bit outside of my scope, but it's because I knew enough about PFD and where we needed to get those referrals. And no one else was there to have that conversation with mom. And so sometimes we do have to be the one that kind of has the rapport and the relationship with that family where they will allow us to have those conversations and facilitate those referrals. Because, we can't just stay in our one little feeding skill domain. When we're working with PFD, we really have to reach out and make those connections to provide that interdisciplinary care to fully and effectively treat their PFD.
That was such a great story, because when I was listening to you describe this experience, one of the things that I remembered as we're talking about team collaboration and making appropriate referrals and helping families understand how other experts or providers might be able to support this journey, one of the things that I was thinking about is that oftentimes we end up being a bit of a team leader, I think, in this area of practice. And one of the things that I say to families is, I can't tell you what it is, but I am here, meaning like an underlying maybe medical cause, but I can help you maybe either think about some questions to ask, or really what we're doing is listening to parents' concerns and parents' intuition and helping them understand, how do we get these questions answered? How do we think about this in a way that helps us to communicate to others that we really do need to take this step? And I don't know about you, but with a lot of families I work with, sometimes it takes a lot to actually reach out and make that medical appointment, right? For a number of reasons, be it like resources, access to care, disparities in access to care or medical care. But I think we can be there as someone who helps parents reflect, and we can help empower parents to ask those good questions. So that was a great story. Thanks for sharing that.
Yeah. And I also love like how you touched on like supporting a parent and following their intuition, because I've had a lot of patients on my case with parents who've said, I've been telling my doctor this for years, but nobody would listen to me. And it's like, Mama, I hear you. Like, I hear you, like having this like pain, this story. And like, I agree, let's dig this in. Like, let's write a really strong referral letter and convince your PCP to send that referral on. Because I don't know, a parent's intuition is so strong. And so always like listening to that and validating it and being there for them is so great.
For sure.
So we had a question that aligns perfectly with our next planned question.
Okay.
What is your treatment philosophy when working with selective eaters?
My treatment philosophy. So, as I mentioned a bit earlier, I consider myself a responsive feeding practitioner. My lens is responsive feeding. And there is a wonderful white paper and then an updated version of that white paper that was written by a group of folks that can give you in detail an explanation of what is responsive feeding. But what I can share with you is that there are specific responsive feeding values that they share in those papers. And one of them is autonomy, that we prioritize a child's autonomy, right? Their ability to decide for themselves based on how they're feeling in a given moment, what is going to work for them. We prioritize relationship. So I've already talked about that quite a bit, but as a responsive feeding practitioner, I approach families who come to me with a lens of holism, thinking about that child within their family, within their environment, and then also more narrowly within the relationships and people they share mealtime with. I think that one of the other things that's really, really important is that we are also supporting competence and skill development. So we are offering a child experiences within which they can find and discover enjoyment, which drives internal motivation, another responsive feeding value. And definitely check out these white papers. This information is from those papers. But intrinsic motivation is just, what does this child love? What motivates them when they feel good physically, when they feel safe, right? When we as practitioners work with parents to identify how to help a child start from the point of safety and trust, we can then help them to have experiences that are internally motivated. So they are exploring and learning and maybe tasting, maybe chewing and swallowing because they want to, not because someone else is compelling them to, right? Or rewarding them for doing it, or punishing them, hopefully that never happens, for not. So we really prioritize that intrinsic motivation as the driver. Marcia Dunn Klein talks a lot about a positive tilt, and that's really something we see physically when, if you can just picture in your mind maybe a parent and a toddler sharing a mealtime, maybe the parent is eating, I don't know, a sandwich, and that baby or toddler leans in and tries to grab it, or the parent holds something out and that child leans in. So it's a coming together either emotionally or physically around a food or an experience. Contrast that with leaning away. So I am always, always, always looking for How do these family members come together with this child around eating? And how does a family member understand that child, understand their skills, understand the just right offer, meaning what are we offering this child in terms of the opportunity to learn right now? Are we offering them a spoon to figure out how to use it? Are we offering them the opportunity to look at the food across the table? Are we offering them the opportunity to be in a room with food? Are we offering them the opportunity to explore a cup? Where do we see that child's internal motivation drive them to lean in and explore? And as we figure out what those just right opportunities are for that child and that family on that day, in that way, we support a child in being able to develop their skills, right? Driven by internal motivation. So you've all probably seen kids who, grab for a utensil when someone's trying to feed them. They want the utensil and they don't do it right. They don't do it efficiently. Right. I actually shouldn't have said right, probably, because right is just whatever way is working for that child at that time. But as the grown-ups at the table, some of us may think, oh gosh, like this is not efficient. But if we take a step back and think about that child as building their skills, I think that helps us to allow this child's learning to happen at their own pace. And then over time, as the child becomes more skilled, their confidence builds. And that leads to a volume of intake. So my approach is thinking first about that foundation of trust and safety. What are those just right opportunities for learning that parents and myself and other members of the team can come up with together, the things that work for that family? And then where do we see internal motivation from that child and enjoyment? And then how do we offer more of that so that they can build their skills? And then eventually they get to volume and maybe diet expansion as they figure out what's just right for them. So that, in a very small nutshell, is my approach to my work with children and families.
Hold up those white papers. I had not heard of them before. I'm so excited that you shared. I know what I'm going to be reading this weekend. And so I put them in the link, but for anybody listening, if you go to responsivefeedingpro.com, it'll take you to their website. And if you search Responsive Feeding Pro white papers, it'll pull up the first one and the revised version 2. But I
Yeah.
just wanted to read this really quick. On the version 2, they have 3 goals listed out, and I love, 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 love these goals. So number 1 is to prioritize felt safety and nervous system regulation.
Yep.
Number 2 is to support and optimize children's relationship with food and their bodies. And number 3 is to provide individualized care, which I just think is so beautiful and like definitely what I'm finding to be like a strong foundation in my feeding therapy, because if you don't have those 3 things, it's really tricky to move past where we currently are.
Yeah. Jenny was one of the early contributors to these papers, so I'm sure she will have much more to say and much more specific information to share about them. But these are really informative papers.
Oh, and I love it too. They're very like multidisciplinary. So they have like lots of different disciplines that kind of participated in it. That's so cool.
Yeah.
So I want to kind of touch on, you said that, we want to focus on skill and then volume increase and maybe diet expansion. So is diet expansion not always a goal when you're working with selective eaters?
So the way I think it really depends on the situation, right?
Mhm.
We've got a child who we meet who is able to eat one food. It's pretty clear that there is most likely a nutritional challenge going on and a nutritional impact. And so in that case, diet expansion absolutely would be a goal, approached by first thinking about why is a more varied diet not working for this child in this moment? Why hasn't it worked in the past? What are their experiences and how did they get to this place, right? Can we start by understanding and helping parents understand? However, I would contrast that with some other folks who might make it to us because someone else thinks their diet is a problem because they eat, maybe what some would judge to be a very short list of foods. But I think that we all need to remember and learn from people like Laura Helfeld and other folks who are sharing their lived experiences that it is very possible to be well nourished, only eating a handful of foods. And so I think that, you and I talked about in our conversation prior to this conversation fact that the other thing that is central to my approach to my work with families and a responsive feeding approach is that last point that you made, that last goal of individualized care. I almost never start out with an end goal of, oh, we've got these like target foods. I would say I really don't. My hope is that through work with children and families, that a child will have the skills and the tools and the felt safety and the comfort to be able to try new foods if and when it's right for them. And so my hope is that if they enjoy trying new foods or they discover things they enjoy that and they want to, that they can continue to do that. But it is not, we've got to get to 30 foods, 40 foods, right? Or it's not that we've got to, have, foods from this group and this group and this group and this group. This is where collaboration with registered dietitians is really, really helpful. Because I think a lot of times when parents come to us, they have been given so much information through the media, perhaps from medical professionals, from friends and family, that the ideal is a child who will eat anything or eat most things or try most things and decide if they like it or don't like it. And so I think that as we as a field shift our perspective from this sort of ideal diet outcome and that eating should look this one perfect way, we can help families have a deeper understanding of this individualized approach and think about, where are we going together and how are we collaborating to find the best ways to support this child's learning. And then I think we discover along the way as we make offers and see how a child responds, right? And what they're able to engage with, we start to learn what's going to work for them. I've got kids who I work with who really only enjoy and feel comfortable with dry, crunchy foods for the most part. And they drank milk. And, but those kids, there is this idea that they've got to learn to manage all these different foods. And yes, it would be nice, it would be easy, it would be less stressful, right? But there are a lot of crunchy foods that offer a lot of great nutrients, right? So I don't know. I think diet expansion, if it's right for that person at that time, if they want to, then great. And it looks different for older people than it does for toddlers. Marcia tells this story about someone that I think it was like a friend of the family. You'll have to ask her about this story, who wanted to try salmon. I think it was because her partner really liked to eat salmon, but she was a very self-described, like restricted eater. She had certain things that she liked, she felt safe with, and that was, how she functioned, and she was doing quite well. But she wanted to try salmon because she wanted to eat it, I think, with her partner. And so she came to Marcia to learn how do I do this? Like it wouldn't have been probably the best approach for her to take a big hunk of salmon and just eat it, right? So one of the things Marcia helped her do was think about, well, you could take a little teeny tiny taste of salmon and put it on a sandwich so that it's not a big, huge, giant smell. So it's not a big, huge, giant taste. And maybe we pair it with things that we know well and feel safe with. So it's just this idea of at all these different stages of development, can we help children and adolescents and adults have the tools and the skills that they need if they meet a food or a situation that they would like to be a part of or like to try?
Definitely love using those like little kind of food chaining with like sandwiches, like small bites, masking flavors, and like building up to a bigger flavor. Salmon is one of my foods that I also want to try. Need to try those tricks. Jennifer, I love your comment that you said. She said parents are in it's been a long day, guys. Is that inundated? Yeah. Moving on with what healthy is for their children. They often feel like they failed when their children are selective eaters. I love how your approach helps caregivers be empowered to get to know their child and be able to figure out what healthy means to them for their child.
Jennifer, you got it. That is it. That is it. Because what you are hopefully, I think, seeing and feeling and hearing is that the language we use is so impactful. And I think it's so impactful when we think about the labels we're giving to children or how we think about foods. I have conversations with every single family I work with about healthy foods and junk foods and carbs and snack foods versus, and one of the things, Karen Dilfer and Karen's an occupational therapist. She's the other third partner in the Get Permission approach, which is our online platform, where we teach about this. We teach about lots of different aspects of feeding based on Marsha's Get Permission approach. But Karen and I just finished up a 23-hour on-demand course. That's a whole nother story. It was not supposed to be that long, but we couldn't stop talking. And we spend a lot of time talking about language and the power of words and the power that words have on our perception and our interpretation of actions and events and experiences. And it's not just the labels that we assign to a pattern of eating or a person, right? But it's also how we think about and describe foods and how we value foods. And so it is so important to think about the words that we choose at every step of the way, including in our verbal feedback and written reports. We have a responsibility to make sure that our language is non-judgmental, unbiased, and simply describes what's happening. And, when parents say to us, well, gosh, my child only likes processed foods and junk food and snack foods, it might be that we help a parent understand, well, lots of those foods are always the same. So they become a very predictable experience for your child. And maybe for your child, that type of food helps them to feel safe. So instead of thinking about the label, right, the junk food, the packaged food, we help parents understand and maybe help adults understand about their own bodies and their own eating, why something might work for them in that moment, and maybe what some other opportunities are that we might want to offer to see if that person wants to explore things a little differently. But I think at a certain point, we have to accept the person who's in front of us, right? Obviously, we're thinking about underlying medical issues. We are obviously primarily concerned with health and medical safety. But I think we get to a point on our journey many times where maybe we don't think we're at the goal, and maybe we could be at a place where we're okay, right? Maybe we're at a place where we can accept who the child is and where the child is at a given moment. And that's different for every child and every family. But as we are being responsive and offering very individualized support, I think we all have to consistently and repeatedly reflect on, where are we right now? Is this okay? Do we accept this child for who they are in front of us at this moment? And do parents accept their child for who they are in this moment? And that's that psychosocial domain where we can overlap with our mental health providers in helping families navigate all of the emotions that are layered on top of medical challenges, nutritional challenges, and feeding challenges.
Jennifer has two other questions, and I think they're both really great. So I know there's a lot of factors for this, but as a responsive feeding practitioner, how do you know a child is ready to be discharged? That kind of fits really nicely with what you were just saying.
Oh,
Another hard one.
is ready to be discharged. So, obviously we're thinking about growth and those parameters, right? We want to make sure that a child is not in like a danger zone in terms of growth and weight gain and just overall health, right? But I think that over time, families start to feel like they can handle the everyday, decisions that they make about those just right opportunities for their child. They understand their children. Marsha talks a lot about not only opportunities, that's a Marsha Duncline word, opportunities being the experience that we're offering on a given day, right? But she also talks a lot about pivoting in a moment. So if we offer an opportunity and a child, it doesn't work for them, it's not the right choice on that day. And as therapists, we will make the wrong offers over and over and over again. We have to tell families that too, because we don't want them to think that, as they're learning, they have to worry about us watching them and saying, oh goodness, we know the right offer. And that's not it. One of the conversations I have all the time is with parents is, my goal is for you to feel empowered as your child's mealtime partner, such that if something isn't going as expected, if something is not working, that you know where to go from here. You know how to pivot, how to modify to either help your child feel safe again, or give your child something that they can fill up on and feel good with. And that child is able to have learning experiences and mealtime experiences that feel good more consistently than not. So it's really a team discussion. based on how the parents feel about how meal times are going in their house and what we together observe about how much a child is struggling. There are some validated measures that are really, really helpful that we can use to measure progress. And that certainly should be part of the equation, right? It's our clinical expertise is important and parent input is really important, but it's really helpful to measure progress in some way. So I really like the family impact scales and the family report tools that are on Dr. Brick Patos's website, and that is Infant Feeding Care, or Infant Feeding Labs is the professional one. She has a number of parent report tools that are validated, and those are really great tools to use to help us sort of understand the change that's happened over time and determine when it might be time to maybe either take a break or say, we've reached our goals. I think the other thing to think about is that we should not be in feeding therapy once a week with a child forever. If that's the case, we're not doing something right. Maybe we have worked with a family and we've made it, the child has felt good enough and competent enough to make lots of change or to come to a place where they're comfortable and they feel good. And maybe there are still some areas to work on, but maybe it's time for a break, right? Maybe the family needs a break. Maybe the child needs a break. Maybe something else can be focused on for a little while, like, I don't know, family life, like going out and like enjoying life. And so feeding therapy can look a lot of different ways, but I think that we also need to think about if we're going once a week and for months and years, do we need to kind of rethink maybe what our stopping point is or what our end goal is?
And then last question, did you go through a special training to be a responsive feeding practitioner? And if not, what is the kind of pathway to being able to call yourself a responsive feeding practitioner?
Oh, that's such a good question.
There's been some, this was Jennifer again. Jennifer is on it with the questions.
Jennifer, thank you. So I should say being a responsive feeding practitioner is not a certification. I didn't finish like a one course, but I have learned from a lot of people over the years, starting with Marcia Dunn Klein and Suzanne Evans Morris, who have been talking about relationship-based feeding and responsive feeding for decades. I've learned from Catherine Shaker, whose work in the neonatal intensive care unit taught me and countless others about cue-based feeding, which is in this sort of same world. I've learned from Ellen Satter, who talks about helping children become competent eaters and the division of responsibility. I learned from Jenny McLaughlin. I've learned from Heidi Moreland and Jennifer Berry and so many people that teach with a responsive feeding lens. And then, of course, Katja Roel and the other authors of the responsive feeding white papers. And so I wish I could say there's like a track. I really like to think that in our Get Permission Institute courses, we offer really comprehensive training from a responsive feeding perspective. And so, right now, it really is about curating your own learning and just making sure that you have the skills to really understand responsive feeding, to understand what that looks like at a mealtime, how to help a parent understand that. But no, really, it's seeking out continuing education opportunities that feel responsive, that prioritize relationships, that prioritize internal motivation, that prioritize autonomy, right? Not doing the thing to the child, that prioritize communication and not just surface behavior, and and approaches and courses that aren't aimed at getting a child to eat, but rather supporting them on their journey. So yeah, I think that like a big sort of issue in our field is there isn't even one sort of certification to be a feeding therapist, right?
Yeah.
We all get varied experiences in our graduate programs, but by and large, as those of us who become feeding therapists and practice in this area continue to learn, we're really curating our own experiences. And so I know that's something a lot of people are talking about and thinking about.
Absolutely. I think Feeding Matters right now is currently like asking, that was a question that came up a lot during the Feeding Matters conference, was like, who do you think should be in charge of like creating like a coursework for a little bit more of like a standardization of care and who can call themselves a pediatric feeding therapist. And then so that'll be really exciting to see where that goes. And then for myself, the books that I read that kind of got me thinking in this responsive feeding framework was Marsha Dunklein's Anxious Eaters, Anxious Mealtimes. I'm currently taking her Anxious Eaters course on the Get Permission approach. It is amazing.
Yay.
I would highly recommend. They have like a whole module over trauma and like how trauma impacts the body, which so many of our feeding kiddos have trauma around feeding from negative experiences. So highly recommend that one. And then the other book that was so enlightening for me and gave me a little bit more perspective, like what the parents are going through and how to counsel the parents, was Judy McLaughlin and Katya Rowell's book, Helping Your Child with Extreme Picky Eating.
Yes.
And then there was a few, like a little bit more of like a subtitle that I can't think of at the moment, but
Yeah.
both of those were like, they are my guidebooks.
Yeah,
So,
both really great choices.
so we did have a question. Somebody asked if this was a series. It is a series. We have 9 episodes. This was the first one. So we have 8 more episodes. We're going to be covering all 4 domains of pediatric feeding. We're doing feeding in the schools next week. We have so many amazing guests coming on. So make sure to check the speechtherapypd.com page. You can also follow me at MaddieMetcalf_SLP on Instagram. And I have it all lined out in a post on my Instagram. I attached Stephanie's Instagram at Learn to Talk with Me. And then you can also follow the Get Permission approach at Get Permission Institute. And yeah, this was so amazing. Stephanie, thank you so much for coming on and sharing your expertise. This was the perfect way to kick off this series.
Can I plug the Chicago Feeding Group real quick?
Please do. I love the Chicago Feeding Group.
So just you all, I know that we're bumping up against the end of our time together, but the Chicago Feeding Group, as you said, Maddie, it's a 501c3 nonprofit organization, and we offer a variety of low cost but very high quality educational opportunities, webinars as well. And, you know, our workshops are free for parents and like $5 for students. So our mission is to offer information in a way that's accessible and affordable to a lot of people. And then also we have a big community on Facebook of professionals and parents just sharing information and expertise and collaborating. So we would love to have you join us there. Our webinars are super low cost as well, because we just believe everyone should have access to high quality education as they learn about feeding and supporting families.
Yes, I've taken some Chicago Feeding Group courses. They are fabulous. Highly recommend. And their Facebook page is so great. And you can ask a question and it'll be answered so quick. It's a great community to be part of. Okay, well, thank you so much, everybody, for joining in. I'm so excited for this mini series and can't wait to see you guys again next week. We'll see you next time on another speechtherapypd.com live course.
Thank you, Maddie. I can't wait for the rest of this series. Take care.
Oh, thanks, you too. Bye, Stephanie.
Bye.
Thank you for joining us for today's course. To complete the course, you must log into your account and complete the quiz and the survey. If you have indicated that you are part of the ASHA registry and entered both your ASHA number and a complete mailing address in your account profile prior to course completion, we will submit earned CEUs to ASHA. Please allow 1 to 2 months from the completion date for your CEUs to reflect on your ASHA transcript. Please note that if this information is missing, we cannot submit to ASHA on your behalf. Thanks again for joining us. We hope to see you next time. Each episode comes with an accompanying audio course on speechtherapypd.com, available for a 0.1 ASHA CEU. And just for our listeners, get $20 off any subscription with promo code SLPLearn20. Speechtherapypd.com is run by SLPs for SLPs. They've got the largest library of ASHA CE eligible courses out there, and they're adding fresh content every week. Remember, use the code SLPLearn20 to get $20 off access to over 1,000 courses for an entire year. Head over to speechtherapypd.com for more information and start earning CEs today. Thanks for tuning in to the SLP Learning Series. And don't forget, speechtherapypd.com is your go-to for all things ASHA CEUs. Your positive reviews and support mean the world to us, and we'd love for you to drop us a quick review and hit that subscribe button.